All right, well, thank you all for coming and staying on this beautiful Hawaiian day when I know you could be outside. I'm going to be talking to you about some of the opportunities and limitations in renal mass imaging. Just to orient you, this is where I come from, NYU. We're all in Hawaii here, but we're in the lower kind of east side here. If you zoom in, you can see we span First Avenue near the East River. Our campus has been broadening recently. We go from about 38th Street down to Bellevue Hospital Center on 25th. And now we're also spreading our tentacles into Brooklyn, Staten Island, and New Jersey. So we've got a large case mix. This is NYU, which was founded in 1837. This is our main site. Our MRIs used to be here until Hurricane Sandy demolished them. Then we put them into trailers and moved them uptown. Bellevue Hospital is the oldest pelvic hospital in the US. This is the IMPay glass addition onto Bellevue, which is a beautiful addition that was put on in about 2000, 2001. Here is the Center for Biomedical Imaging, which is at 38th Street. You can see there are the trailers here. This is where our 1.5 Teslas were moved after Hurricane Sandy. And this is our home base. Many of you may know Dan Sodikson and Dr. Boda. This is our site. Again, we have the trailers with the 1.5, and then we have 2 3 Teslas on site. We have a 7 Tesla, and we have a PET MR, as well as a cyclotron, which is going to start producing in a year and a half. So we have extensive MR facilities. Here is Eric Sigmund. He's giving a lot of the sequences and talks this week. He's at the 7 Tesla. This is our current number. I think my chairman keeps telling me I'm underestimating the number of magnets that we have. This is mostly our on-site and Manhattan numbers, but we have many more than this in our off-sites. And so with that introduction, this is our 3 Tesla renal MR protocol. We essentially do have a very long sequence. Many chairmen will not allow you to have such a time-intensive magnet hogging sequence if they're focused on clinical revenue, but we've been pushing the limitations that we can. We do a coronal and an axial haste. We do an axial in and out. Diffusion is mandatory for the kidney. We do it at 0, 400, and 800, which is pretty much the standard based on the inverted ADC. And then we have pre and post contrast vibe. We cover the liver on one of our vibes just in case there's some lesion that we didn't pick up that we want to make sure we characterize later. And finally, we do a coronal delayed vibe. We also do it in sagittal now because our renal surgeons have said that they find the sagittal gives them a more accurate depiction of where the renal mass is relative to the rest of the kidney. All right, so with that kind of background, I'm going to go into a little bit of the clinical context with how we're using MR imaging. So we know renal cancer is about 3.7% of all cancers, and it's only 2.4% of all cancer deaths. That puts it behind the big players that get more funding for research from the NIH, like breast, lung, prostate, lymphoma, colon, and bladder. And the other, kind of interesting point is that most of these renal cancers are incidental, so like less than 10% produce with any symptoms. And we know that those are going to have a better prognosis than those that do present with symptoms. What is interesting in this as well is that our mortality rate is not improving. So we know that we've been picking up more cases due to incidental cross-sectional imaging, but the death rate is unchanged over time. And that's because we haven't changed in picking up the advanced cancers that present late with regional disease or metastatic disease. And so from this, we know that although we were not picking up as many because of less imaging in the 70s, we really haven't changed this death rate of about 14,000 per year. And because of this, most of the current literature will tell you that we realize that we've just had a stage migration by picking up tumors with a longer lead time, but we haven't affected the length time bias. And so what a lot of people are saying is we're not really doing any benefit by picking up these smaller tumors. How does that parlay into us? Well, I'm going to try and show you some data on what we can do to be useful. Maybe we can characterize better those aggressive tumors, and how can we subtype lesions to kind of say which ones are safe to watch. So our prior role of MR really in renal mass lesions is finding the mass and seeing if we can depict internal enhancement. And these skills can be tricky. This seems like a no-brainer, and we're expected to do this, but I'm going to show you how we can have pitfalls in this. And what is the future role is we really need to be subtyping these lesions. And I'll tell you, even as we've been mastering distinguishing clear cell from papillary, the pathologists keep changing their WHO classification, and I just had a talk from Ebley at our institution about this change, where you're adding more subtypes and deleting others. And I'll tell you, papillary type 2, they were debating for the 2016 of eliminating this classification, and they decided to keep it there to let it die off naturally, because translocation tumors, collecting duct tumors, with all of the immunohistochemical stains they're doing, they're actually finding that type 2 papillary was a mixed bag. It wasn't a pure group, and instead of deleting it from the WHO criteria, they're going to let it slowly die off as they get better at putting it into the real categories. So why do I have this slide here? Well, when we're predicting these subtypes, we're chasing pathologists because they keep changing the rules on us. So it's a little bit of a game here. I think radiology is better. I'll show you where I think we beat pathology here. All right, so our roles of MRI, we're going to do cyst versus tumor, and then I'm going to show you how to do some subtyping of renal cell carcinoma. So how do we determine MRI enhancement? They're subjective. You look at the pre and you look at the post and you say, I think it's enhancing. Then there is this article from Ho, and I always get scared when presenting this at an MRI meeting like this because the physicists, I hope there's none in the audience, they cringe when they hear us putting ROIs on any MRI image because there's no noise map, and because the transmit gain and receive gain differ from the pre to post, so it makes it completely inaccurate. And I know for a while physicists had been working on making a noise map to make these ROIs accurate, but for the time being, it's not accurate. As long as you accept that people will cringe with this, this is at least reasonable to do. So what this paper was, and I still use it, is you look at the pre, you minus the post, you use the 2 to 4 minute delay post-contrast, and you stick ROIs on it. And if a physicist walks by, you just say, leave me alone, I'm reading a clinical case. And so you can operate like that. And the other way to do it is subtraction. You do the post minus the pre, and if it's bright, then it usually means it's enhancing. All right, so here's a good case. This is a calcified dense mass, and you look at the pre and the post, and you say, is this enhancing? Impossible to tell. So this is a clear-cut case for MRI, and here on MR, you can clearly show on the inside there's this peripheral nodularity, and this was a cystic RCC. Some people may say when it calcifies, it may be burning itself out, kind of like seminoma tumors, but that's in the air because people have shown METs even with those type of tumors, but that's neither here nor there. All right, so here we are back to the pitfalls. ROI measurements. Be careful if the enhancing region is too small for your ROI if you're going to put it on it. And the other is subtraction misregistration, and subtraction noise is additive. All right, so here is one, and I'll tell you, I love this case because part of the Radiology 2.0, our institution decided to put us more into the clinic with our urologists. So I get to sit in this clinic room with the urologists as they're going through their cases. And over time, that room has evolved to have me sitting next to 3 med students and a nurse practitioner with boxes falling on my head. But it is still radiology of the future. And at least I get to see clinical cases as they're happening in real time. So here is this man. He came in, and this was read as an RCC. It's bright on pre, arguably enhancing. I don't think it is. So you put your ROI on it, it goes from 44 to 53. That's only 9 Hounsfield units. Most of us would say that's not enhancing, but this was read by someone in the community as an enhancing mass. But they said it maybe you want to get an MR. So then they got an MR. So this was their MR. They did a pre here, and they did a post here. And if you visually look at it, it looks like it's de-enhancing as you go from pre to post. You can put your ROI on it, and you see the number is also going down from pre to post. Any lesion that's de-enhancing is benign. okay? But the problem was they relied on their subs. And what you can see here is they misinterpreted this as enhancing. But those of you with an eagle eye will see there is this thickened white rind around the liver. And what happens is because this was at a higher level and they breathed at a lower level post, your subtraction is going to be misregistered. And so in reality, here is the ghosting of the non-enhancement of this renal cyst. So this is one of those FAFA syndromes. In radiology, our surgical chairman loves to say fumble after fumble after fumble after fumble. And so this was almost resected as a cancer, when in reality it's a benign renal cyst. And so just be aware of these pitfalls. That's misregistration. Another one, and this goes into a nice sidebar, which is kind of one of the American College of Radiology's current priorities is these incidental lesions. How do you know when you don't need to work up anything? And these are some nice papers that have been out. You can ignore on non-con simple cysts less than 20 or greater than 70 Hounsfield units. And this just came out recently. Gary Israel did some nice work on this, showing that very bright bloody cysts that have a signal intensity of 2.5 when you take the lesion to the parenchymal ROI had a 99.9% accuracy of being benign. And finally, Silverman did a nice article on if a lesion looks like a cyst and it's tiny and it's smaller than a centimeter, you can just ignore it. All right, and so in this case, if you had just looked at this cyst and you said, you know what, this is brighter by more than 2.5 relative to the parenchyma, you can ignore it, and this is benign. So that was another takeaway. And finally, my last example of pitfalls with subtraction are this corollary case. Here we have a mass in the lower pole of the left kidney. Here on T2, it looks really irregular and ugly inside. So you can visually look at it, and from pre to post, hard to say. You can look at the wall, because often the wall is the hint as to whether these are enhancing. But it was equivocal, so then they looked at the subtraction. This was interpreted as internal enhancement. But beware, if you're looking at the subtraction, look at the noise around it. This looks just as noisy as what's going on in this cyst. And that's the problem with subtraction. Noise is additive. So if you're relying on this to look for subtle enhancement, you're going to get fooled with low level. And in this case, actually, they also looked at diffusion, and here's the B400 for diffusion, and you'll see it's really not that bright and it's not restricting. And ultimately, they got a CT, and it got smaller, and it didn't show any enhancement. This was interpreted as benign. It's anyone's guess if this thing actually was a burned out tumor or not, but regardless, it behaved as an indolent lesion. So I'm going to go into a little bit of some advanced MR techniques looking at renal tumors and see how they can help us. How good is diffusion? And I think the prior speakers were going through the limitations of diffusion in terms of endometrial cancer as well as adnexal lesions. It's kind of the same thing for renal as well. It's not there yet for solid bloody cancer versus cysts. Cystic, and it's all because of cellularity. It's not there for cystic RCC. It's starting to be promising for solid RCC. And really, why is it so limited? It's a signal issue. It's because signal is low and the cellularity is low. And this is a constant problem in a lot of these tumors. So for example, here's a nice article. My colleague, Sue Kim, who's in the audience, looked at how good we are at ADC values, and you see this overlap, although RCC does tend to be lower than benign lesions. If you look at the whisker plot of this, there's overlap, so you can't rely on it alone. Here we have a cyst, which is bright on ADC, and here's a papillary, which is uniformly dark. Those are the two best tumors that behave according to the rules. The rest are a grab bag in between. And again, here's a nice article from Zhang showing that the ADC overlaps. So if you draw a line here, you're going to get overlap between almost all of these. But again, there is a trend towards ADC being lower for solid lesions. This is a nice article by my section chief, Hirsch, where he showed how papillary RCC here has a lower ADC, but you'll notice the other tumor subtypes, including chromophobe, clear cell, and cystic, all essentially overlap on ADC, so it doesn't help us there. What he did show that was interesting is if you look at the intervoxel incoherent motion, which is the beginning part of that curve on ADC, looking at the perfusion characteristics from the diffusion curve, you'll see that the papillary had a much lower perfusion fraction, and you can get good separation of the tumor subtypes. Here we've got chromophobe, clear cell, and then you've got your cystic RCC, and this does show better differentiation. So this is an evolving area that we're showing some promise. All right, and now for the second half of the talk, I'm going to discuss some of the subtypes of RCC. And I'm going to focus on some of the more tricky cases. And just again, as a quick review, AMLs, clear cells, and chromophobe RCCs are all going to be hypervascular. So you're going to need to rely on other sequences to distinguish them. Papillary is probably the easiest because it's hypovascular and it doesn't show arterial enhancement. When I say papillary, I'm talking about papillary type 1. Again, as I mentioned before, papillary type 2 is probably going away. It was almost kicked out of this current WHO 2016 classification. Here's a nice flow chart if you're interested in it from Kang AJR in 2014, kind of going through, again, the low-level enhancement you see in papillary RCC and the avid enhancement you're going to see in the other tumor subtypes. Again, there's some overlap in all of this. All right, quick review of chemical shift artifact. It's interesting, in my training, I trained in Boston at Beth Israel Deaconess, and Herb Kressel was the chairman at the time, and he used to come in and tell me, just use the T1 in and out. Those are the most important sequence. And I was like, this guy's out of his mind. These are 8mm thick slices. This is so ugly. It looks like a 1980s MRI sequence. I think he's crazy. But I've learned with my life that he was right. And I actually find more information from this sequence than from a lot of the others. And when I've missed tumors, I usually go back and I see it was actually there. So I am going to try and proselytize you to be converted to the T1 in and out of phase sequences, and I'll go through why. So intravoxel is going from in to out. You're going to see loss of signal. When people talk about loss of signal in clear cell RCC because of the glycogen-rich clear cells in it, they're not talking about something going from bright to super dark. They're talking about this type of loss of signal, and it's subtle. So it goes from this degree of brightness to this degree of signal loss, and that's subtle, but it is going from bright to dark. That's what people are talking about. It's not something obvious. You have to really look at it, and you can put on that dreaded ROI and look at the loss in signal from one to the other. And it is seen in both clear cell and in AMLs. All right, and what about bulk fat? And I'll tell you, bulk fat on MR is the hardest thing in the world, and it is really difficult. People will talk about using this line, and I actually wrote this up with Gary Israel when I was a resident, and it was looking at this black line at the interface of water and fat, and if it's between bulk fat and the water, that tells you that it's going to be an AML. And if it's between the lesion and the bulk fat, then it's something else. In this case, it was a hemorrhagic cyst. But I'll tell you, this sign in and of itself is subject to a lot of artifacts. You can have edge artifact, you can have some other hemosiderin mimicking it, so it's not perfect. What I would advise you to do is look at the signal in the lesion and look at the bulk fat in the subcutaneous space. And if it's following what the bulk fat is doing on every sequence, you've got to think that it may be an AML. And it's not easy. All right, and so we're going to go down this flow chart and see if we can subtype a few lesions. All right, here we can go. We've got a pre-contrast T1, and we're looking at this lesion. It looks similar to the fat in the subcutaneous, so we're thinking it's probably bulk fat. I will say the problem with VIBE is that it is both an opposed phase, so it has both intravoxel fat as well as a frequency-selective fat-sat sequence. So it's not ideal to use for this because if a lesion's going to lose a lot of signal on the opposed phase, you may get fooled. But anyways, this is what we have. So we're going to say, it looks like bulk fat. We go to the next one, and here we have this is her demographic. As soon as you see she's a 40-year-old female, you're thinking an AML. Okay, middle-aged, female, AML. But still, we're gonna go through the exercise. In to out of phase. Is there bulk fat? Does it look like bulk fat on this sequence? Yes. Okay, then we go to the next one. And it has that dark line at the interface. But those of you that are savvy are gonna say, Nicole, I see that dark line at the interface with it. Fine, I'll say, I told you this was not a perfect sign. Okay, intravoxel fat, does it go from bright to dark? Yes, it does. All right, and is it enhancing? Yes, it is. So in this case, you're gonna think of an AML, and here again, is it uniformly low on T2? No. Is it following the bulk fat signal? Yes, so you know that this is gonna be an AML. But if you're in doubt, you can get a CT. This is how hard bulk fat is. It's not easy. It's not like a CT. Here's a corollary case, 72-year-old man. Wrong demographic for a benign lesion. These are the people who have bad cancers. So we see it's enhancing. Is it going from bright to dark? Is there bulk fat? Do we see a black line with the adjacent kidney? No, we don't. So we say it doesn't have bulk fat. Does it have intravoxel fat? Well, yes, it does, and it has a lot of it. And is it low on T2? No, it's heterogeneous. So this is gonna be a clear cell renal cell carcinoma. And finally, going to this one, here's a 45-year-old female. What are we thinking? Age group, this is going to be likely an AML. That being said, women in this age group do get cancer, but you're favoring in your mind an AML. It's enhancing. We go from bright to dark. Is there any loss of signal? No, there's not. So there's no fat. There's no bulk fat. We don't see that dark line with the adjacent kidney, and it's not following bulk fat in all sequences. And however, it is uniformly low on T2. And I'll tell you, this was actually a lipid-poor AML, but there's no way you can do this. There's no MRI technique that's perfect for this yet, and so that's why a lot of the guidelines, and including the current ACR guideline, I think it's coming out in JACR this year, on the guideline for this workup, is probably recommending biopsy for these dark T2 lesions. All right, and here is the next one. Another 40-year-old female right renal mass. Is there internal fat? Does it look like the subcutaneous fat? It does. And there's also quite a bit of loss of signal. We can see, again, it's following bulk fat on this sequence and on this one. But I'll tell you, this was read as avidly enhancing. It was read as a clear cell. But this was an AML. So what I'm just warning you is bulk fat is hard on MR, and CT is just much easier. You can see the internal fat in the lesion here, as well as the classic aneurysms. So this is not something that's easy, and I've noticed my colleagues who are specialists in this have missed about 5 of these AMLs because it can be hard. They should have a greater loss of signal in a post phase when they're fatty. India ink is not always obvious, and if you're in doubt, just go back to CT. I know this is an MR course, but sometimes it's just easier. All right, now I'm gonna go through some low T2 lesions which don't have fat. And so here is one of the other challenge. These are T2 dark lesions. Are they benign or malignant? Well, this one is homogeneously low on T2. It has no blood on T1 pre, and you can see it is enhancing post-contrast. This is one, it's low on T2, it's not so homogeneous, it has hemorrhage, which AMLs never have, and at least not the lipid-poor ones that are dark on T2. And on subtraction, it's got heterogeneous enhancement. So looking at the pre, I already know this is gonna be a papillary because papillaries bleed. And so this one's a papillary, this is a lipid-poor. Again, there's no data that can confirm this. That's why these are going to go to biopsy every time. So we're just not there yet with subtyping for that. All right, how good are we at predicting tumor aggressiveness, which is gonna be the next stage? We know cystic appearing RCC are less aggressive. You really need to only call it cystic if less than 25% of it is solid. We know high stage are gonna be more heterogeneous than low stage RCC. And also, as was shown with the discussions on response of tumor, the high grade are lesions that are gonna have more necrosis tend to have a lower ADC compared to low grade. It's kind of counterintuitive, but you have to think it's probably because it's so aggressive and it's necrosing. What is the role of diffusion? Again, high grade tends to have a lower ADC. And one of the problems is not all tumor subtypes show diffusion restriction. I showed earlier the slide from Hirsch from our institution showing that papillary is pretty good at doing this, but the other subtypes really don't help. And I'm going to show some examples on why you cannot rely on diffusion alone for screening. I'm going to show you some cases where I've been burned. All right, so here's ADC for prediction of tumor grade. We can see which of these looks like it's more uniformly dark. That's going to be the lower grade. This one is more uniformly dark than this one, and this was a lower grade clear cell than this one. All right, so it's a bit of a judgment call. How about diffusion as a standalone? Okay, this is a man who had already lost his right kidney. Here you have this heterogeneous mass on haste. In and out of phase, we see that loss of signal, so we know that this is going to be a clear cell renal cell carcinoma because it's going from bright to dark, from in to out of phase. And on the ADC, it looked like there was some good restriction there. So we figured, it showed diffusion restriction, so this guy got his partial nephrectomy, and afterwards had already lost one kidney. I know we're a little aggressive. We do partial nephrectomies, even for these aggressive tumors. Probably was not the right call in this guy, as I'm going to show you next, but he really wanted it. He didn't want to go on dialysis from this. So we screened him for 2 years after his partial nephrectomy, and he refused to get IV contrast. And can anyone in the audience find the recurrent tumor? Well, it took us a while to find this, and he came back, I said, for 2 years. And finally, you can sort of suggest maybe that's going from bright to dark. Very difficult call. Really, like I said, Dr. Kressel's hint of using the in and out of phase was a better call here because I looked at this and I said, that renal vein actually looks expanded. And it all goes back to our favorite sequence, T1 in and out, because diffusion just let me down here in a big way. And so as you go, we called him back for dynamic contrast. That tumor had recurred. It was infiltrating and going along the renal vein and now involving the retroperitoneum. And diffusion just ignored it. You don't see any of it. So I'm not the biggest fan of diffusion alone for these sequences yet. However, it can be helpful. Here was another case where it did help. Here was a renal cell, aggressive. Again, the guy got a partial nephrectomy because he was trying to preserve his kidney. And as you go to the post-contrast, here's the partial nephrectomy site. Here, and actually, Sue, I believe you picked this up when you were here with us. You can see that there's this implant in the rectus abdominis muscle, but it looks like bowel. Here, diffusion was bright and did show diffusion restriction, so it was helpful in this case for picking up this recurrence. This recurred there because that's the way they resect. They do an anterior resection, and they pull out the kidney specimen through that port site of that anterior abdominal wall. So this is a place where you can get recurrent disease after a partial nephrectomy. A good pickup. So kind of what's our future directions? Can we replace pathology in subtyping renal lesions? That's really where we're trying to go. And we're hoping that we'll be able to do that based on enhancement and perfusion, and maybe we'll obviate the need for a biopsy, kind of like the direction MR elastography is going, and where HCC characterization went. So we're hoping that that's where we go. Can we predict which tumors, when they're advanced stage, are going to respond to VEGF, and which ones won't, and which ones we need to use neoadjuvant, and which ones maybe will be better served by doing an immediate resection? And finally, can we use non-Gatto techniques? There's a real demand in these patients who've lost part of their kidney. They don't want IV contrast. They'd love it if our diffusion was more accurate. I don't think we're there yet, but it would be great for the day that we could get there and use it to monitor for recurrence. So in conclusion, MR has a proven role in determining enhancement in renal lesions, especially when CT cannot in calcified lesions. Be aware of the pitfalls of MRI enhancement. Look carefully and use your ROIs on it, even though physicists cringe. Subtyping renal lesions is a needed skill. It's going to come into play more and more as how they're monitored and surveillance imaging is used in the future. If we can predict those lesions that are going to have an indolent course versus those that are going to be aggressive, it's going to be important. And also, you don't want to operate on AMLs in women. I do feel we're going to replace pathology someday. And diffusion and IVIM are promising techniques, but they still have a way to go. However, I'm optimistic we're going to get there. And I'd like to just say Dr. Bosniak, one of the fathers of renal imaging, passed away this past September, and he's deeply missed already by all of our colleagues. And McCary, who was one of the leaders of our section, also passed away in 2012, the same time as Sandy. And this is Dr. Balthazar, one of the founders of GI radiology, and they're all deeply beloved and missed. Thank you.